Hey everyone, welcome to week 10. I'm sorry that we're not meeting in person this week, and I wholly appreciate your understanding. This is Amy Reeb, and we are going to focus on drugs affecting the respiratory system this week, chapters 54 and 55. Let's get started. The objectives were obviously written before I knew that we were canceling class, so I guess we're not going to meet number 5 this week. Hopefully we will meet the remainder of the objectives. You read chapter 53 this week, and if you didn't, I would strongly recommend it unless you have a phenomenal command of the respiratory system. This figure is very similar to the one that we have in chapter 54. Let's start with the oral cavity here, and above that we have our hard palate, and if we go posterior we have our soft palate. Continuing posteriorly we have the nasopharynx, oropharynx, and the laryngopharynx. Going upward we have our nasal cavity, frontal sinuses. The maxillary sinus is not shown on this one. We have the cranial cavity, and I miss having you there to pronounce words for me. We also have the sphenoid sinus. Down here we have the entrance to the eustachian tube. Other drugs would call this chapter drugs for allergic rhinitis and or the common cold. But let's talk about things that we use to help treat the symptoms of upper respiratory infections. Big thank you to all of you who sent pictures of your beloved furry pets and some not so furry pets. I think it's really going to help since I cannot call on you and or throw chocolate around the room. We're going to discuss 5 classes of drugs in this section. The first one are our antitussives. These block the cough reflex. Next is going to be our decongestants, which decrease the blood flow to our upper respiratory tract to decrease the overproduction of secretions, again providing symptomatic relief. It's not fixing the problem, but it is helping to alleviate the symptoms. Next we have our antihistamines, which block the release or the action of histamine that increases the secretions and causes inflammation or narrowing of the airways. The fourth class that we'll talk about are our expectorants, which simply increase the amount of the productive cough to clear the airways. Sometimes I'll tell patients that it helps to thin the mucus to make it easier to cough out, sneeze out, blow out, whatever we got to do. Last class that we'll talk about is going to be our mucolytics, and this also will then increase or liquefy the respiratory secretions, again helping to aid the clearing of the airways. For our visual learners, here we have the sites of action of our drugs which work on the upper respiratory tract. Let's first highlight the medullary cough center here located in the brain, and this is very close to where our cough suppressants, including things such as codeine, hydrocodone, and our dextromethorphan. Boy, I wish you guys were here to pronounce these things. This is where those are going to work, okay? We can see then in the nasal cavity, that's where our topical nasal decongestants as well as our nasal steroids will work. The inhaled steroids that we're going to talk about in chapter 55 work down within the lungs. Our expectorants are working down within the mucal layer within the lungs, down by the cilia here. The antihistamines are working in the layer just below that, and the bronchodilators that we'll talk about again in later chapter are working more on the smooth muscle within the lungs. Finally, our lung surfactants are working within the alveoli. Just in case you did not read the previous chapter, the upper respiratory tract is responsible for warming, humidifying, and cleaning incoming air. The nasal mucosa is richly supplied with vascular tissue. You know this anytime that you get a patient with a raging nosebleed. Sometimes that can be a little tricky to stop, especially if their blood pressure, if their systolic is greater than 140 or 160. It is controlled by the autonomic nervous system. It is one of our first lines of defense. It's helping to prevent particulate matter and pathogens from getting inside the body, from reaching our bronchioles as well as our alveoli. Again, it is the first line of immunologic defense. So we have our ciliated epithelium, our nasal mucus, and our mast cells that help line the nasal mucosa as our little defenders against particles and pathogens. As your book says, the cough reflex serves a very important purpose. The walls of the trachea, as well as we go down the bronchi, are very, very sensitive to stimulation and irritation. Again, it's part of our defense system. When they are irritated, we have our signals through the central nervous system to produce the reflex through the medullary cough center that then gets us to cough. So what an antitussive does is it acts directly on that medullary cough center of the brain to try to depress the cough reflex. Again, there's a reason that we cough, so these should be used with caution. The primary indication is to control a non-productive cough. I don't usually prescribe nor do I recommend antitussives unless it truly is a non-productive cough. And even if I do at that point, I'm only going to prescribe it for very short terms with very specific instructions, such as take it before you go to bed if this non-productive cough is keeping you awake, or take it if you're a pharmacology professor and have to do lectures for 6 hours on Fridays. Just kidding. But again, think about it. If there is mucus, if there is pathogens trying to work its way down to your bronchi, you don't want to suppress that cough. You want to be able to get them out. Pharmacokinetically, antitussives are rapidly absorbed, metabolized in the liver, excreted in the urine. They are contraindicated in somebody who needs a cough to maintain an airway. Losing an airway is bad. It's also contraindicated in severe head injuries or somebody with impaired CNS. Again, we are working up in that medullary cough center in the center of the brain. We have some opioid antitussives and non-opioid antitussives. Our opioids are primarily codeine and hydrocodone. And again, occasionally I will prescribe some sort of cough suppressant with a little bit of codeine, but if I do, it's with very specific directions for use. Just to be sure that we are clear, when the cough is beneficial, we should not suppress it, such as the productive cough that is characteristic of our chronic lung diseases, such as emphysema, asthma, or chronic bronchitis. Caution needs to be used, obviously, for hypersensitivity. If you're allergic to it, don't take it. Narcotic addiction, obviously you know that some of these medications are opioids, and thus if there's a history of narcotic addiction, we have potential for abuse. Hydrocodone is Schedule 3. Codeine by itself is Schedule 2, but when mixed with other antitussive mixtures, it's actually Schedule 4. According to a different textbook that I have, it says that dextromethorphan is the most effective over-the-counter non-opioid cough medication. It obviously does not cause the opioid euphoria or physical dependence. Adverse effects, we might get some mild CNS adverse effects, perhaps a little bit of sedation. Obviously, our opioids will cause increased sedation. We'll see drying effect on the mucous membranes, and sometimes we'll see a little bit of GI upset. Of note, benzonatate, or good old Tessalon pearls, should not be sucked on or chewed on because they can cause a bronchospasm, laryngospasm. One book says circulatory collapse. Obviously, that's bad. And it looks here like Mowgli agrees with me. I wish we all could have like this much focus on pharmacology. Our prototype is dextromethorphan, which is found in children's Robitussin, children's Thiaminic, Delsum, Robitussin 12-hour cold relief, Vicks Dayquil. Again, it suppresses the cough center in the medulla to control cough spasms. It has a pretty quick onset, usually about half an hour. The downside is that it can only last 3 to 6 hours, so we might be taking it QID or up to 6 times a day. Again, adverse effects are CNS things such as dizziness, respiratory depression, and we also talked about dry mouth. The next drug class that we will discuss is going to be topical nasal decongestants. So these have the similar response to stimulating the sympathetic nervous system. In doing so, it causes vasoconstriction. The result is that there will be less inflammation, less swelling of the nasal membrane. These work really, really quickly. They make people feel better fast. It's only indicated to relieve the discomfort of nasal decongestion that accompanies the common cold, sinusitis, and allergic rhinitis. Here's the big star for you, for a short period of time. One text says do not use longer than 5 consecutive days. I've always been told more like 3. So because this is topical and local, our nasal decongestants generally are not absorbed within the system, so usually we will not get systemic effects. Anything that is will be absorbed and metabolized in the liver, excreted in the urine. Contraindicated if we have lesions or erosions of the mucous membranes. Those are more chronic. We actually will use something like our ephedrine spray to try to help resolve a nosebleed, simply because of its vasoconstrictive properties. Obviously, caution with any condition that may be exacerbated by sympathetic activity. The adverse effects of our topical nasal decongestants include local stinging and burning. Some people are more sensitive to this than other. Rebound congestion, that's the one that you need to know. When these topical agents are used for more than 3 to 5 days, when the effects of the medication wear off, we will then get vasodilation, which gets worse. I had a 7th or 8th grade history teacher whom I'm sure was pretty addicted to these nasal sprays. I'm sure I might have told you the story about Mr. Randolph, who would use them quite often in the classroom. Ew. Drug-to-drug interactions you probably do not need to know. See, look, this big yellow lab is warning you. Be sure to tell your patients not to use this for more than a few days. Again, ephedrine is our prototype summary. It does activate our alpha-1 adrenergic receptors on our nasal blood vessels. Works pretty quickly, usually just a couple minutes. Lasts about 4 to 6 hours. For the most part, it's really not absorbed systemically. So the adverse effects are more with topical side effects that we already talked about. Let's do a question so that you're staying awake out there. True, false? Antitussive agents should be used with caution in patients who have a history of addiction. That one looks like it was too easy. Even the puppy looks tragically bored. That is true. Caution should be used in patients who are hypersensitive to or have a history of addiction to narcotics.
The next drug class is oral decongestants. Actions. They shrink the nasal mucous membrane by stimulating the alpha-energetic receptors in the nasal mucous membranes. Indicans. Promotion of drainage in the sinuses and improving airflow. Pharmacokinetics. Well absorbed, widely distributed in the body. Metabolized in the liver and primarily executed in urine.
When we compare our oral decongestants with our topical nasal decongestants, we know that oral decongestants, this is when we're thinking of things such as phenylephrine, ephedrine, pseudoephedrine, like Sudafed. We know that they are going to have more systemic effects. The response time is going to be slower. They are less effective at relieving severe congestion. They're usually combined and over-the-counter with other antihistamine-type preparations. In this case, contraindications going to be any condition that could be made worse by sympathetic activity. So think high blood pressure, tachycardia. The rebound congestion is much more rare with our oral decongestants than it is with our nasal topical. Drug-to-drug interactions, over-the-counter products that contain pseudoephedrine taken concurrently can cause some serious side effects. We'll see a high incidence of our central nervous system stimulation. And as you know, these are the drugs that are kept behind the counter. That's done to reduce diversion to labs that make meth. There was something that I did not have to learn when I was in nursing school. And this guy looks about as thrilled with lecture as some of you may be right about now. Hang in there, we are more than halfway done with lecture number 1. Alright, we're up to slide 18, and the next class that we will cover is going to be our topical nasal corticosteroids, otherwise known as intranasal corticosteroids. Our book calls this topical nasal steroid decongestants. Get rid of the word decongestants. That's going to confuse you with the topical nasal decongestants that we just covered a few slides ago, okay? Think steroids, okay? So the exact action, the mechanism according to our textbook isn't known, but we know that steroids reduce inflammation. So these topically, locally reduce tissue edema. They can cause mild vasoconstriction, which is why our book wants to throw the word decongestants in there. So they are decreasing the secretion of the inflammatory mediators. These are really the drugs of choice in treating our allergic rhinitis. It's the most effective for both treatment as well as prevention. If we're using it for prevention, they really have to be administered a couple weeks prior to the allergen exposure. Again, indicated for seasonal allergic rhinitis as well as inflammation treatment after the removal of nasal polyps. For the most part, these are not usually absorbed systemically. How ironic, my husband just brought me chocolate because it's late and I'm tired, and I can see that Fluffy would really like some. If I could throw some over to Fluffy, I would. So our intranasal corticosteroids are contraindicated in acute infection simply because steroids block the inflammatory response. With steroids, we have to consider the increased risk of a candida infection, yeast infection. We want to avoid exposure to airborne infections, and well, we generally want to do that anyway. Adverse effects are usually very, very mild. We might get some topical local effects, so local burning, irritation, stinging, dryness in the mucosa, and or headaches. Again, we might get some very mild, and again, mild suppression of healing can occur in a patient who has had nasal surgery or trauma. It's not something that we worry about tremendously. Again, rarely we can see nosebleed and or drying of the nasal mucosa or sore throat. I actually think omeprazole nasal or Nasonex should be our prototype, but they're essentially all very, very similar. Again, treatment of seasonal allergic rhinitis, and I disagree with the part that says who are not getting any response from other decongestant preps because we don't necessarily want to use those all the time. Again, these have anti-inflammatory properties. Onset is usually pretty quick, but sometimes with our nasal corticosteroids, it's going to take a while to build up to the full effect, okay? This is not the Afrin spray where you utilize it and you immediately feel better. Sometimes it's going to take 3, 4, 5 days until we start to get much better. And again, adverse is usually localized. Burning, irritation, stinging, dryness in the mucosa, headache, and increased risk of infection, maybe. The next drug class that we have is our antihistamines. When I say antihistamines, you just think Benadryl, okay? So our antihistamines selectively block the effects of the histamine at the histamine 1 receptor sites, so it decreases the allergic response. We will see both anticholinergic and antipyretic, anti-itching type effects. These are utilized for seasonal and year-round allergic rhinitis, allergic conjunctivitis. We can also utilize it for uncomplicated urticaria as well as our severe angioedema. Again, if used for allergic rhinitis, they're going to be most effective if taken prophylactically, taken regularly throughout the allergy season, even when the symptoms are absent, to prevent that initial histamine receptor activation. Pharmacokinetics, they're well absorbed, metabolized in the liver, excreted in urine and feces, contraindicated in pregnancy and lactation, or at least used with some caution. For our antihistamines, which are also called H1 blockers or H1 receptor blockers, we want to use a little bit of caution for renal or hepatic impairment, as well as people with history of dysrhythmias. The adverse effects include drowsiness and sedation, which is much more prevalent with our first generation antihistamines. The second generation antihistamines, not so much. Occasionally, for some people, we might see a paradoxical CNS stimulation and excitability. That occurs in like 10% of the population. And I remember when I was taking a trip, 14-hour plane flight over to South Korea with my 18-month-old son at the time. Don't think poorly of me, but I did ask my pediatrician if I could give my sweet one some Benadryl at all during that flight. My pediatrician actually recommended it, but gave me the warning to make sure that I tried it first, because what if I did this and at 33,000 feet, Marshall happened to be one of the 10% that Benadryl caused CNS stimulation. That's not what you want to find out on a 14-hour flight. We also have some anticholinergic effects, dry mouth big time, maybe some tachycardia, which is why we want to be cautious with the people with a history of dysrhythmias, and maybe some mild hypotension. Drug-to-drug interactions really vary based on the drug. And I love these friends. I think we'll have another picture of these two coming up in the next lecture as well. Our prototype antihistamine, or H1 receptor blocker, is going to be Benadryl or diphenhydramine. Again, it competitively blocks the effects of the histamine at the H1 receptor sites. It does have some mild sedative effects, especially first generation Benadryl, Our second generation, our Zyrtec, Allegra, Claritin, not quite so sedative. Again, adverse effects, drowsiness, sedation, dizziness. Epigastric distress, don't see it often. We might dry things out, so we'll get some thickening of the bronchial secretions, and then our anticholinergic effects as well, which should include tachycardia, not bradycardia. The next class that we'll talk about are expectorants. When we say expectorants, think guaifenesin or Mucinex. I should point out here, kind of important to note, this says Mucinex DM. D stands for the decongestant part. So this is a combination product including a decongestant, an oral decongestant, which is going to stimulate the sympathetic nervous system, and an expectorant. This would be located behind the counter for my patients who are taking ADHD meds, high blood pressure meds. I warn them, just plain Mucinex, just plain guaifenesin, nothing with a D on it. Alright, so what does an expectorant do? It enhances the output of the respiratory tract fluids by reducing the adhesiveness and surface tension of these fluids. Thus it allows easier movement of the less viscous fluids. So again, it renders the cough more productive by stimulating flow of the respiratory tract secretions. Higher doses may be more effective than lower. Pharmacokinetics, this is rapidly absorbed, and according to your textbook, metabolism and excretion have not been reported. We could probably assume, like most of our other drugs, that it is the liver and the kidney. So the only expectorant that we have is available in the U.S. is guaifenesin, which is available over the counter in a whole bunch of different products. Adverse effects might be some mild GI symptoms, headache, dizziness, mild rash. If we do prolonged use without knowing why we're using it, we might be masking a serious underlying disorder such as chronic bronchitis or something like that. Nursing interventions, make sure that these patients stay well hydrated. It's going to work a lot better if the secretions are more thin, more liquid, and again, ensuring that they're well hydrated will also help promote that. And our prototype again is our one and only guaifenesin, and I think we covered all of that. Oh, onset 30 to 60 minutes, peak is unknown. Most of the time, unless we're using a long-acting formula, duration is about 4 to 6 hours. So typically this will be taken usually QID PRN. Making sure you're still awake out there. Question: which of the following is an adverse local reaction to our topical steroids? Will you see increased nasal drainage, a rebound effect, suppression of healing, or local ulceration? Think about it. Don't make me call on names. It's awfully quiet out there. The correct answer is C. There is a slight increased risk of, or an adverse reaction would be, suppression of healing. Other adverse effects that we might see include local burning, irritation, stinging, dryness of the mucosa, and headache. Suppression of healing can occur maybe sometimes. The last topic of this chapter is mucolytics. Mucolytics work to break down mucus in order to aid our high-risk respiratory patient in coughing up very, very thick, very tenacious secretions. So these are for patients who have cystic fibrosis or perhaps chronic bronchitis, any other disease which is producing very, very thick mucus. Indicated for patients who have difficulty coughing up secretions, patients who have atelectasis, Sometimes we'll use it for patients undergoing diagnostic bronch, maybe postoperative patients, and occasionally patients with trachs. Maybe sometimes we'll see that we'll break that out. The one that I've seen most often used in the hospital setting, in the ICU, would be acetylcysteine, otherwise known as mucimus. I think I slaughtered that word. Sorry, you guys. That is also the antidote for Tylenol overdose. The reason that the egg is there is that when your patient is getting a nebulizer, a mucimus nebulizer, it really does kind of have that sulfur type smell. Pharmacokinetics, usually this is administered by neb. I've never seen it direct installation into the trachea. We need to be careful with acute bronchospasm, peptic ulcer, and esophageal varices. Increased secretions could make those worse. Adverse effects include making your nurse smell that hideous rotten egg smell, GI upset. We might see rhinorrhea. Well, that's kind of what we're open for. Again, we could have bronchospasm and occasionally rash. This sweet little guy looks a little pensive about our sulfur smell. Our prototype again is acetylcysteine. I hope I pronounced it correctly this time. Again, it's adjunctive therapy for abnormal, very, very thick mucus secretions. In case you wanted to know, but do not need to know for the test, it splits the links in the mucoproteins and thus decreases the viscosity. Again, we'll also use mucimist or acetylcysteine for acetaminophen overdose. When it is used via neb, onset within really quite quickly, we're inhaling it, so a minute or so. It's going to peak in about 10 minutes and last for 2 to 3 hours. I know I usually glance over some of our age considerations because you can read it, but I think we do need to talk about our pediatric population. New guidelines came out several years ago, maybe 10 years ago or more, because there's a lot of over-the-counter cold preparations for children. Latest guidelines really say that we should use these in extreme caution, avoid over-the-counter cold remedies in children younger than 4 to 6 years, use only our products labeled for pediatric use, to be sure that a healthcare professional is consulted prior to giving these drugs to a child. We really should consider some of our non-pharmacologic measures, and being sure that we're using proper dosing is a really big deal. Again, on the other end of the spectrum, with our older adults, we need to remember that sometimes they are more prone to some of the adverse effects, especially some of our anticholinergic effects with some of the medication classes that we talked about. Since I can't use Kahoots on this lecture, Hunter asked me to ask you some questions. So, which drug enhances the output of the respiratory tract fluid by reducing the adhesiveness and the surface tension of the fluid, which then facilitates the removal of the viscous mucus? Wow, Hunter asked a difficult question. I would easily look at this and be able to break it down between two of them. Let me let you think about it for a second. If we're technically reducing the adhesiveness and surface tension, the correct answer is going to be C, acetylcysteine. I think that question was splitting hairs a smidge. I'm not sure that I would ask something like that on an exam. Next question, a patient asks which medication would be most effective in the treatment of seasonal hay fever. You will teach the patient about the use of which drug? By the way, nobody actually sent me a picture of a goldfish. I was kind of surprised. And the correct answer is fluticasone. Intranasal glucocorticoids or intranasal corticosteroids are the most effective agents used to treat allergic rhinitis. Final question, wrapping this one up. A patient is prescribed codeine as an antitussive. Which symptom will you observe for as an adverse effect of this medication? Is it going to be A, respiratory depression, B, increased heart rate, C, productive cough, or D, restlessness? The correct answer is A. Codeine is an opioid that can suppress respiration, so we need to watch for respiratory depression.